Hello, everyone, and welcome to Your Healthy Dose with Kim Douglas, a podcast about current trends in healthcare. And I'm very excited about the two doctors that we have on today's show. First, we have Dr. Timothy Wilson.
Hello.
Hi. He is the Director of Urology and Urologic Oncology Research Program right here at St. John's. And Dr. Maran Mavasagi, Director of Men's Health.
Good morning.
So welcome to both of you. I'm so glad you're here with us today. I want to start by having both of you tell us a little something about you and your credentials. Let's start with you, Dr. Wilson.
Sure. I'm a country boy. I grew up on a farm in Northwest Oregon. And then I was a Stanford undergraduate. And then after that, went back to Oregon to go to medical school. I did my surgery and urology training in Los Angeles at LA County USC Medical Center. Then I did my fellowship in urologic oncology at City of Hope Cancer Center in Duarte. Then I practiced there as chief of urology for 25 years.
Wow.
And then following that, I was recruited here to the St. John's Cancer Institute as professor and chair of urology and urologic oncology.
Wonderful. Love that. And how about you, Dr. M?
So I'm an Iranian implant to Los Angeles, but like the millions of Iranians here, we've been living here for the last 30 years. I did my undergrad at UCLA and medical school and business school there as well. I went to Stanford for residency, then wanted to be close to Tim, so I went to USC to finish up. Did fellowship at Cedars and did a couple of years in private practice, and then ended up at St. John's here, Director of Men's Health. So
wonderful. Well, lucky for us that you're both here. And I have to tell you guys, these two should have their own show. They really, I mean, you're very...
This is an interview, right?
Yeah, exactly.
Yeah,
you never know.
You're too kind.
You never know. All right. So let's talk about prostate cancer.
Sure.
What can you tell us about it? And also, how common is prostate cancer in men?
Well, so prostate cancer, in fact, is the most common cancer in men in the United States, and also the second leading cause of cancer death in men. So it's extremely important in that regard. Average age of diagnosis is about 60 years old. So we note that the most important risk factor, it turns out, is age. As men age, the risk continues to increase, unlike many other cancers where there's a peak incidence, like at a certain age group, but
it still keeps going.
It still keeps going up. We know that when diagnosed early, it's highly curable, and so it's very treatable. As I said, about 30,000 men die per year from prostate cancer, and by screening, we can find it early, diagnose it early, and then offer men curative treatments.
Perfect. And we're going to get into that a little bit more.
And interestingly, screening is actually really important because a lot of patients ask us, well, I don't have any symptoms. And that's one of the things is that prostate cancer doesn't have any symptoms. You don't get up at night. It doesn't change your urinary stream. You don't have any signs or symptoms that technically enlarged prostate shows. But it's really important that men get checked and screened regularly because it's something that they would never know they have.
And so when I want to ask you about how it affects the men's quality of life, what you're basically saying is it doesn't.
Well,
if you haven't.
In the early stages, it doesn't. But if you let it go and don't get it diagnosed, then it can.
Okay.
And I think before we had PSA screening, patients would show up in the emergency room with, metastatic disease, and they couldn't walk, or, they were in retention, and it's because the cancer had spread to their bones. But since the 90s that we've had PSA and all the advances since, we've been able to stop that and make it essentially a 100% curable disease.
Yeah, I think one of the important things, as Maron alluded to, is that men are very good about their healthcare anyway.
Period.
But they're afraid, right? Yeah. Yeah. So they're afraid to get checked for prostate cancer. I think there's a huge misunderstanding about what happens if you have prostate cancer.
Right.
Men have the perception that you'll become kind of an asexual being, and that's simply not true.
That is really encouraging to know. So before we go into more of that, how often should men get screened? Let's just start there. How often?
I think it's relatively controversial in terms of who you ask. But I think if we, as urologists, we try to basically follow the American Urologic Guidelines. There's some risk factors, including family history. If you're African American, you should start earlier. But generally speaking, most men should start getting screened at around age 50.
50. Okay, and you had said 60 was that kind of...
Well, kind of the peak.
For,
but as
cancer.
If there's a family history, or for African-American men, or if there's some genetic risk that's been discovered, like BRCA positive, that sort of thing, same gene for breast cancer.
I know.
Right? Then we would recommend that those men begin screening earlier at age 40.
That's great advice and so important for all of our listeners and watchers to know. So how important is that genetics and lifestyle as it relates to prostate cancer? Lifestyle too. We haven't really touched on that.
So the only diet or lifestyle that's actually been shown to affect prostate cancer and prostate health in general is the Mediterranean diet. So if you kind of subscribe to that diet, none of these fad diets, not keto, not low carb, et cetera, you've actually seen an improvement in both for patients that have diagnosed prostate cancer and their outcomes, and also in preventing prostate cancer. And the other interesting tidbit about exercise is that 35 minutes or more, 3 times a week of high intensity exercise, not walking, not just kind of, oh yeah, I do this, I walk the dog out. No, high intensity has actually been shown to reduce prostate cancer risk.
Yeah, I think that, along those lines, what we've come to believe is that whatever is kind of heart healthy is cancer preventative in general.
Yes.
And those things apply to prostate cancer. I think in terms of diet, I think in terms of risk, we know that, Western diets, unfortunately, are put us at increased risk, high fat diets, lack of exercise. But, in fact, used to be in Asia, for instance, like in China, prostate cancer is relatively uncommon, but is one of the few cancers on the rise in China because of the adoption of kind of Western diets.
Isn't that interesting? Mm-hmm. We had touched a little bit on why men avoid medical screenings, and I think there's a lot of reasons for that, right? But are there cultural and gender issues that make it difficult for men to just even discuss issues like prostate cancer, where women were always like, oh, have you had your mammogram? Right. Are you, we're so different.
Well, if you look at when and how much men utilize healthcare, there's basically a peak. So when your mom takes care of you, you do really good. And we are basically at equal with women. But then between the ages of 18 and about 55 to 60, we utilize healthcare at 50% relative to women. Now, some of that is because women have kids and so on. But nonetheless, as a guy who's dealing with men's health all the time, guys just don't want to come to the doctor. And we're fine until we're not. And so, it's usually the spouse that drags their husbands or whomever into the doctor's office. And, that's a major problem. And I think the stigma is, forever and ever, we were the breadwinners. We couldn't stop working. We also didn't want to be vulnerable to having disease or anything because we're supermen. And that's, hasn't really changed much, even though we've made so many advances.
I think we see that even among physicians. I mean, and myself personally, I think that, where all of us are busy, you're going to do it next month or, next week, but something comes up. I was supposed to go to the dentist last week, but I was in the operating room and had to call him and cancel again. Yep. So, even I've had personal friends that were doctors that got diagnosed late and eventually died from, colon cancer. So it happens to physicians too. Men are notoriously bad for taking care of themselves.
I think you're so right. That was so interesting about when your mom's taking care of you. I know that.
That's why I miss my mother.
I know.
You want mine?
Oh. Okay, no mom jokes, you guys.
Yeah.
Seriously.
I love my mom.
Yes.
I love my mom.
I'm a mom.
She'll probably hear this.
Yes.
Most important person of my life.
Exactly.
Absolutely.
And Dr. M's mom, we love you too. Okay. So we did also, you said a little bit about this, but can you go any deeper into the major misconceptions about prostate cancer and the treatment and the screening, the misconceptions about it?
Yeah, I mean, I think that men are simply afraid. Number one, men are afraid of being examined. So the common test, as Dr. Mofsagi alluded to earlier, is a blood test, this PSA blood test, and an examination, a digital examination of the prostate, a rectal exam. And a lot of men are afraid of that. But it's an easy exam, number one. Doesn't hurt. They shouldn't be afraid of it. The blood test is simply a blood test. And I think men don't want to do it because they have the perception that if they're diagnosed, that they will no longer be a sexual being. They won't be able to have sex anymore, and that simply isn't true. Once men are diagnosed with prostate cancer, they still can feel intimate and close with their loved ones, their spouse, their significant other. The treatments of prostate cancer don't change the sensation of the penis. Treatments for prostate cancer don't typically, they can, we'll talk about that, but usually in the early stages, we don't use hormone therapy, so sex drive hasn't changed. And although erections and the ability to have penetrative intercourse may be affected temporarily, usually those things recover. And furthermore, that's a separate neurologic event from orgasm or climax, which shouldn't be affected. Again, I suspect later we'll talk about later stages of prostate cancer and the hormone treatments and that sort of thing. But early stages don't usually affect those things.
And the other misconception, which Tim was talking to about the blood test, the PSA, is, this has become, it's come under fire as to being a bad test. And I think a lot of primary care doctors, which usually kind of serve as the gatekeeper for a lot of men for their health care, have kind of thrown this to the waistline because they've, it's come under scrutiny that it's not a good test. And if you compare data from the 80s when there wasn't a PSA to data when there is PSA, you see that prostate cancer went from being an incurable disease that showed up with mets or spread to a curable disease. And in 2014-15, there was kind of a change in recommendation by the U.S. Preventive Task Force that you should no longer screen men by a blood test. And that, when we looked back at the data from that one recommendation, we saw there was an increase in metastatic disease for prostate cancer. So the takeaway is that PSA is not a perfect test.
Right.
It's a screening test. And in the last decade, we've made so many advances on if someone has an elevated PSA. 10 years ago, the recommendation was go get a biopsy, which is invasive and intrusive, and we try to avoid that now. Now the recommendation is more blood tests, urine tests, tumor markers, bioassays, liquid biopsies, imaging with MRI, and even some of the treatments now where a decade ago it was remove the prostate, zap the prostate. Now we have focal therapy that is really precision down to removing just the cancer itself.
So I think that what Mayor Ron alluded to earlier is really important, that early on, if men have the blood test and the PSA is elevated, we don't just automatically go to a biopsy anymore. So we have many more adjunctive tests which help us determine which men actually need a biopsy. And then using things like MRI, we can be much more accurate in how the biopsy is done and more find out with more accuracy whether or not prostate cancer actually exists.
Yes.
And then once we find it, if it is diagnosed, we have so many more options now that are available, from careful monitoring to radical therapy, depending on what's needed for that individual.
Right. And I actually have heard and done my research on YouTube, and I hear that there's even robotic assisted surgery for this.
When? Oh.
Yeah, that's right. You two are out of a job. No, but could that be a wave of the future?
So robotic
assisted.
Yes, robotic assisted or robot assisted radical prostatectomy has been around now for 20 years. Yeah, so there's a company called Intuitive Surgical that in the late 1990s developed a robotic device that's not programmable. It's entirely controlled by the surgeon. Allows us to do it's a device that hovers over the patient and attaches to small tubes or ports that allow us to work like a laparoscopic surgery, but with more accuracy. So it's a more consistent, more reliable, more reproducible way of doing prostate cancer surgery. During this, just a couple of things. So during the surgery, the surgeon is able to look inside the abdominal cavity into the pelvis, where we inflate the abdomen with gas, actually to create kind of an amphitheater in which we work. and there's very little blood loss. We see things with about 14-fold magnification. Interestingly, unlike laparoscopic surgery where the instruments go in and out and rotate and grab things, with robotic surgery we have wrist action. So the surgeon sits remote, a few feet away from the patient, while they're under a general anesthetic. You look inside a viewer, and we move some joysticks, and at the same time, the robot moves in concert with the surgeon's hands. And we're in about the 6th generation of robotic surgery. So there's been a lot of advancements over the last 20 years in that technology.
Wow, that is amazing.
Yeah, and joking aside, he was actually one of the pioneers. He's been doing this since the very beginning. So he's helped the company develop some of these tools.
Wow.
So we're very fortunate to have him as our chair.
Speaking of, it was first surgery was done in a covered wagon.
On his farm.
On his farm in Oregon.
Well, so a little tidbit, right? So the device was originally developed as a tool for the battlefield, to kind of do remote surgery in the battlefield, where it never been done. But the concept was that the surgeon would be in one spot. There would be a mobile operating theater in the battlefield, and then the surgeon could be somewhere else, which could happen remotely, and control the
They've done some of those. It just hasn't been.
So there has been remote surgery. The first time the device was demonstrated, over 20 years ago, the surgeon was in New York and the patient was in Paris, France.
Oh my goodness. Yeah. Isn't that amazing?
Yeah. Well, we have other robots too. In fact, St. John's was the first hospital in the U.S. to acquire a Focal One machine, which is another robot.
Right.
It's a robot, but it's for high intensity focused ultrasound. So it's a little different than removing the prostate. The way that this works is that you essentially program the robot to emit ultrasound beams directly to an area within the prostate that has the cancer, with a margin that the surgeon determines, and without any cutting, without any sort of downtime, the probe is inserted transrectally, and the surgery takes anywhere from 30 to minutes to 60 minutes, and the patient goes home the same day.
So these, even though these treatments might seem competitive, or like they compete with one another, but in fact they don't. So they complement one another depending on the details of the cancer.
Right.
So depending on, the health of the individual, the stage, or how advanced the cancer is. Is it confined? Is it just in one part of the prostate? What's the aggressiveness level? We offer all these treatments here in terms of, just simply careful monitoring. We have some naturopathic things like button mushrooms, a button mushroom study for naturopathic kind of treatment, focal therapy for treating part of the prostate, or the whole prostate might need treatment with either surgery or radiation. Again, we'll like to think that we can tailor the treatment to the individual to get the best possible result while minimizing complications.
It sounds like it. It really does. Now, tell me if there's any exciting things, or if we already pretty much hit on them, on the horizon. Sure. On the horizon, because it does sound like all of these things are being built up even more.
Well, there's laser surgery. Mm-hmm. So there's a new machine that's still kind of its infancy, but instead of going through the rectum, can go through the urethra and essentially ablate because some guys have both an enlarged prostate, so they have urinary symptoms related to that, but they also have prostate cancer. And this surgery can essentially treat both at the same time without removing the entire prostate. So that's coming. It's around, but hasn't gained as much acceptance.
Not yet.
Well, I think some of the things we're doing at the Cancer Institute involve genetics.
Yes.
So studying the genetic makeup of the cancer to determine, even though it might look, so the standard way of assessing the aggressiveness was something called the Gleason's grade and score. It's a rating that the pathologist gives the cancer cells as to how aggressive they look, which means...
So is that like level stage 3B?
So a little different.
So the grade is the aggressiveness, how fast it's going to grow, and its propensity to spread. The stage, I always remember this from medical school. The professor said, like all the world's a stage. So it refers to how advanced how advanced it is. Is it confined to the prostate, or is it outside the prostate? So there are some newer imaging modalities, for instance, not just MRI is advanced over the last decade tremendously. There's newer PET scan called PMSA, prostate membrane specific antigen. It helps us try to find out, is the cancer confined to the prostate or has it spread? And then we have some new techniques we're looking on to try to look at the genetics of the cancer specifically to tell beyond the Gleason's grade and score, is it really going to spread or not? Or what's the likelihood it spread?
What I tell patients when we try to explain this is, the Gleason score is what it looks like under the microscope.
Okay.
Right. So it's essential. But the genetic testing tells us, is it actually acting the way that it looks?
Yeah.
Because if something looks aggressive, may not necessarily act aggressive. And the genes that we test for and what genes are turned on or turned off will allow us to make a more kind of informed decision in terms of, well, maybe watchful waiting or the careful surveillance, as Tim calls it, would be appropriate for one patient because they have cancer that not only looks not aggressive, but it also is acting not aggressive. Whereas if you have a different kind of cancer, kind of an in-between stage, and it's acting more aggressive, you may say, you're young, it might make more sense to treat it all and be cured versus deal with it for a longer time to come.
Right. And although we've been talking primarily about men that are first diagnosed and early diagnosis and what we call organ confined disease or just cancer that's limited to the prostate, there's now many more advancements for men that have, when they're first diagnosed or if they develop spread or metastatic prostate cancer. So that, being a pioneer, and doing this for so long, when I started at City of Hope in the 1990s, in the early 90s, there weren't very many treatments for men that had advanced prostate cancer. And when those men were diagnosed, they would typically die from their cancer within 18 months to 2 years. Even though there aren't definite cures from men that have metastatic prostate cancer, those men now live on average 8 to 10 years. So the systemic treatment with excellent quality of life. So the kind of advancements in systemic therapies and medical therapies has been tremendous.
I would say so. Now we are going to get into one of my favorite topics. Let's talk about you two on the personal level. So I know with you, Dr. Wilson, that you were raised on a farm in Oregon, which I love. But what inspired you from being a farm boy, John Deere, probably riding tractors and stuff, to pursuing men's health? And then I'm going to get to you you're from Tehran. So, I can't wait to hear how you two got into men's health. What inspired you?
Well, probably actually my family doctor, a guy named Lyle Ackerson, was probably my inspiration to become a physician. He was well respected in the community, and it was a small town. So the town I grew up in was about 5,000 people. We were, so everyone knew each other. It was a very middle-class community. But so Dr. Ackerson was a close friend of my parents, took care of me when I was a kid. I have 4 brothers, took care of all of us. And so, and because I think of the respect he had in the community, it inspired me to kind of want to mimic that or follow in that sort of field. So I originally thought that I would after college, go to medical school and try to become a primary care physician. But then during medical school, during that time, you do rotations in surgical subspecialties, and urology really kind of fit my personality. So, it is primarily men, but there are women obviously that need urologists as well for bladder dysfunction or urinary tract infections or kidney stones or urinary bladder cancer, kidney cancer, things that we take care of as well. But men are special, as we've talked about. And
are they, Dr. Wilson? Are they?
And because urology is a little bit of an offbeat specialty, and urologists are generally fun-loving and good-natured, and it's a very interesting field, actually.
You have the perfect personality for it. So tell us about you. How in the world did this men's health come to you?
So for me, it was more of a personal kind of journey. So when we immigrated from Tehran, my parents thought that I couldn't do anything. They kind of kept me at home, no sports, no going out. And so I basically ballooned up from the age of, 7 when I came here, and I was probably at normal, weight, height. Well, no, now, but it's very different. There's the ugly years. So, and basically between the ages of 7 and like 17, I just ate and gained weight and kind of adopted the American lifestyle. And at one point I was 5'3", now I'm 6'1", and I weighed 195 pounds. So for me, to learn about fitness and eating well and kind of making a decision of going into healthcare, that was kind of a no-brainer. And then when it came time to kind of choosing what kind of career path I wanted, I knew urology was kind of a hybrid in a way that we can incorporate a little bit of general care, and I don't want to call it primary care because we don't, but there a lot of things that urologic, for example, erectile dysfunction, have a lot to do with cardiovascular health. In fact, we say that you can get a glimpse into a man's heart by looking at his penis, because there's essentially a 10-year window where if someone has ED at age 40, they're at much higher risk for developing cardiovascular disease by age 50 and having a heart attack. So there was a lot of, correlations, and so it just at the same time fit my personality. And so when I had the opportunity to start a men's health program, that really was kind of where I wanted my, my career path to go and my passion to go. And that's what I've been doing for the past 12 and a half years.
So interesting. So important that you flip the script on
right. Now my wife calls me a manorexic. That's okay.
I think you look great. You look absolutely great. Oh, goodness. You guys are so fun. Well, as we're wrapping up, is there any message that you'd like to tell our listeners about prostate cancer or men's health issues? Just your kind of summing it up.
I think the key for men's health is, just listen to your body, because sometimes your body's telling you things, and, just to ignore it and saying you're fine, it's not. And, get a doctor, get someone who you feel comfortable with, even if it's once every couple of years, get checked out. And, screening for prostate cancer is very important. So don't ignore that.
Important.
Yeah. I think, don't smoke, exercise, eat a heart healthy diet, get an annual exam with a primary care physician, and do what they say.
Yes.
Okay.
There's the big key right there. Yeah. Well, that's all the time we have, unfortunately, for today. But thank you both so much, Dr. Wilson and Dr. M, for being here with us and sharing this important information.
Yeah. Thank you for the invitation.
And thank you to St. John's Health Center Foundation for making this possible. And thank you all for joining us today. So until next time, I'm Kim Douglas with your Healthy Dose.